I think Mark left me with no mean feat to convert that vision for the future into a perspective of where the NHS currently finds itself and where we might go in the next 3 years. But I wanted to reflect before I really started was to just think through Mark's point around impact and really thinking through the work that has been done by all of you in this room and how that's being bedded into where we go next within the NHS. So impact beyond the individual research outputs, but how it's shaping the landscape of the whole of the UK for the long term within and beyond the NHS. So a little bit of my perspective is to start with Data Saves Lives. You'll have hopefully had an opportunity to read this recently, two of the large documents we've recently launched, which aims to lay out how the government is approaching its ambitions around harnessing the potential of health data and care data across those use cases that Mark described. Within the NHS, we talk about care, planning, population health, and research use cases. So 4 rather than 3, but the same themes as Mark has outlined. And the ambitions within that are really to reflect, again, on the learnings from the pandemic and to ensure we're bedding those lessons into how we think about the long-term ambitions of delivering care, delivering research and innovation, and laying out the roadmap of how we go through that in the next 3 to 5 years across the NHS. So some of the context, again, all of you will be familiar with in this room, that generally there's a high level of support and engagement with the NHS using data for providing exceptional care and a high level of willingness to use that, and we've seen that particularly during the pandemic. But we've also seen an increase in opt-outs. This has been reflected in the experiences of GPDPR as well as elsewhere. And so one of the core fundamentals, and it's the first chapter of the Data Saves Lives strategy, is rebuilding trust and transparency, engaging in an ongoing, not brief windows of conversation with the public, but co-creating and continually reimagining the conversation about how data is used, the impact of its use, and the benefits for allowing the sharing across the ecosystem. We've made, as I say, a range of commitments within that strategy, the first of those being around trust and transparency in how data is used in health and social care. It's also about giving access to the people that need it most to deliver that care, so making sure they've got those pieces of data at their fingertips across primary, secondary, tertiary, across mental health, using the ranges of data we have available in a much more linked up way. That we can improve the data quality and availability in adult social care. We know that social care is significantly far behind healthcare. We need to embed the lessons we've learned through the last 5 to 10 years with NHS data and really improve the system for social care and allow better integration. That we can support local and national decision-making with data, and again, this is talking about making sure we're deriving insights around planning, population health, ensuring we're putting the resources where we need to across the length and breadth of the country. That where we sit from my perspective in the world, that we're empowering researchers with the data you need to develop life-saving treatments, diagnosis, preventions, and early interventions. That we're working in partnership to drive those innovations, and that we're developing the right technical infrastructure, so in part trusted research environments, but as well as supporting better linkage of data throughout the system across care planning, population health, and research. So this was launched in draft format in June 2021. We spent a long period of time taking on board a large swathe of feedback and input into refining that. And that final strategy was launched 2 weeks ago on Monday. As I say, if you haven't had a chance to read it, I would highly recommend following Jess Morley on Twitter. She is exceptional at taking a pre-seed version of very complex documents and creating those into bite-sized components. And she's done that for both Data Saves Lives as well as the Goldacre review. So Jess is part of the core team that was responsible for developing the Goldacre review. Ben and his team were commissioned to review how we approach a more efficient and safe use of access to health data for research and innovation. And again, that was published in the last couple of months. Similarly, there are over 170 odd recommendations in there. If you haven't had a chance to digest and process all of those, there's a Twitter version to get your early insights. But it really does, between the two of those documents, lay out where we're headed in terms of shifting the ecosystem for health data research and innovation. So there are, as I said, a number of recommendations. I'm not going to go through them all. The deck is available for anybody who would like it, if you don't want to go through the documents themselves, but covers platforms and security, modern open working methods, so really thinking about how we're being more open and reproducible in the data processes we're involved in, how we're approaching data curation and knowledge management, assessing the data analyst expertise both within and beyond the NHS, so how we're providing the specialist workforce we need to improve data quality, supporting curation as well as analysis of that data. The governance wrapping around those, so particularly assessing some of the ways we might tackle information governance in a more streamlined way. And then approaches and strategy covering the overall responsibilities within and beyond the NHS in terms of delivering on some of this. One of the key things that was referenced within that document was around trusted research environments, or as we're framing them, as secure data environments. We're shifting away from research because, again, to Mark's point, there are uses that are critical beyond research for access and use of NHS data, and we need to cover all of those umbrella terms in how we're approaching this. And also, we shouldn't take trust for granted. These should be secure environments, and we need to earn and continue to maintain trust rather than sticking trust on the front and saying we've got it cracked. So we're approaching this differently. We will be testing this. If you have feedback on that approach, do tell us. But that policy work is really focused around how we're building the right secure data environments, both, as I say, for research by academia and industry, as well as for planning, analysis, and population health management. And that builds on an awful lot of work done by HDR UK and the hubs, demonstrating best practice in terms of trusted research environments, embedding that into policy from the Department of Health and Social Care. So we think that there has been this mandate for change. I oversee, as David mentioned, the £200 million data for R&D programme. That will be supporting and embedding NHS-led, managed and operated trusted research environments for research use, as well as providing the mandate through the backing of Goldacre, as well as laying out in that data strategy where we're headed, how we're going to implement the recommendations from Goldacre, not in terms of just policy, but also funding from within the NHS, as well as with colleagues in UKRI and NIHR. So laying out a little bit of what the national policy will lay out in terms of core components. Within Data Saves Lives, there were 7 draft policy principles, which I'll go into in a moment. Those are one of the core deliverables that will be aiming to help support the system in understanding what we expect in terms of delivering of secure data environments. That those will be supported by technical capability specifications to tell you what the minimum specification you are required to meet. And finally, an accreditation framework. In order to give public and patients and the system as a whole confidence in the way we're approaching this, we want to be able to accredit these environments, to say to the public, you can expect X, they've had the gold star, we know they're safe, we are happy for these people to be managing and using your data. So this is obviously a significant shift from where we currently sit in the landscape, where there are pockets of this activity, but variability in terms of approach and implementation. So this is a roadmap that we'll be going through in the next 3 years. We're not turning off data sharing, but we are shifting from data sharing to data access, and we'll be seeing the many, many data sharing agreements shift into being the default is by access through a secure data environment. And that is the first of the SDE policy principles. They will be the default means by which particularly research and innovation happens within the NHS with NHS and social care data. We know there will be exceptions to these. We want those to be as few and far as possible so we can provide clarity about where you go, what you do, and how you do it, as well as to the public and patients about how research and innovation is happening with their data. That the SDEs will provide access, that they must meet those accreditation criteria and will be assessed through the accreditation framework, that they must maintain the highest level of cybersecurity, that we expect owners to be transparent about how data has been used within that environment, and again, that leverages a lot of the work that's been done through the digital innovation hubs, that they may only be accessed by appropriate and verified users. So again, trying to reinforce clarity about who has had what access to do what in what environment. That we really do, again, embed in the same way the hubs have done, patient and public involvement into the way that those operate at all levels of those trusted research environments. That they are de-identified, the data used is de-identified in a proportionate manner. And this is important, again, I think, to get into the granularity of we don't think there is one size fits all. There are solutions and there are models that will work for open safely type approaches to data use within a TRE, and there are others that very much will require a different eyes-on solution. And we have to have appropriate and proportionate solutions for the anonymization of data to meet those research use cases. that we should support linkage with datasets within only those accredited environments. So we expect if you wish to maintain your trusted research environment that you will go on that journey with us about becoming accredited, and linking and supporting movement between TREs will require that accreditation. That we will enforce policies around open working, code sharing and RAP, building on the recommendations from Ben's review, and that we must support a flexible and high-quality analysis environment, and that really this has to continue to be agile and evolve as more research and innovation use cases emerge. And finally, that there is nothing brought in or removed from those environments without assessment approval. So again, this is going to be a big people shift in terms of data sharing versus data access, but we have to have confidence that nothing is leaving those secure data environments that we're not content to. These are in draft, as I said, in Data Saves Lives, and we are having ongoing work with HDR UK and other stakeholders about how this evolves over the next few months. So I'm going to shift gears a little bit. So this is a bit about policy. I'm now going to talk a bit more about my world in delivery. So the Data for R&D programme itself has a vision that by the end of 2025, we'll have supported a world-leading NHS-wide, and I'll pause there because NHS-wide for my world is across England. It's not covering the whole of UK, but is focused on our investments into England, but really is about all of England, not pockets of academic excellence. I come from Oxford. This isn't about Oxford. This is about covering the breadth of country so we can make that data available across all of England. And that research infrastructure that we build can enhance patient care, coming back to Mark's point, that we can sustain the NHS, and this talks about both financial and non-financial benefits back into the NHS in terms of adoption of innovation, as well as commercial benefits from uses of NHS data, and fundamentally supports innovation. And the objectives of the programme itself are that we will have an England-wide ecosystem of NHS-owned and managed infrastructure, and this is both at a national level as well as regionally. So, sorry, I can't recall who was talking about regional being a key component and bridging that gap, but this is one of the core pieces, is thinking both what NHS Digital and NHS England offer at a national level, as well as supporting pan-ICS level collaborative multimodal data research, that we can enhance patient and public support and enthusiasm for NHS data use. We've heard about DigiTrials already today. DigiTrials is embedded into the Data for R&D programme now. So through that and other activities, we can increase clinical trials capacity, as well as the volume and variety of people offered an opportunity to be part of research. That we can expand the ability to access and link genomic data assets across the country, and this is work with GEL, Biobank, Our Future Health and Bioresource. And then finally, that we embed and generate the returns back to the NHS through access to and uses of data through a applied set of principles about commercial uses of NHS data. For those of you that are familiar with some of the work we've been doing in the last year, this is delivered through two core strands. So the Data-Enabled Clinical Trials programme, which incorporates the Find, Recruit, Follow-up activity, which is, as the name says on the tin, how do we find people? How do we recruit them into studies? How do we both identify and then communicate with those groups? And how do we follow them up long term? How are we supporting data-enabled clinical trial operations? And that's particularly focused around NHS Digital and DigiTrials. How do we make it more straightforward to navigate through the system to find the right data for the right study? And we'll be linking up with some of Emily's work from CoConnect, so thinking through, again, how are we helping find cohorts of the right participants, and really tackling some of the feedback that we hear from industry and academia that during the pandemic, it was so much easier to find where you needed to get to because there was a common direction and purpose. Now we're back to we need to do research on every use case. Where do I go? What's the right source of data? How do I get my study underway effectively? So trying to link up more parts of the ecosystem to support that. And finally, working through trail recruitment capability, combining the potential of the NHS app with activity led by NHR through Be Part of Research to provide new opportunities for patients to opt in to research, to actively engage and be engaged through clinical trials work via digital platforms and solutions. So linking up, again, different parts of the NHS beyond into NHR and others. And then on the other side of this, we have our data access and linkage components. And this is, as I say, focused on our trusted research environments. So nationally with NHS Digital, regionally across ICSs, and specialists through the genomic data assets. And those are underpinned by some of our policy enablers. So the secure data environments I've already talked to you about, the commercial principles for how we approach data access and what fair value looks like, and then embedding within the programme, as well as funding the national conversation that we'll be having from NHS England with the public about how data is used within the NHS for care planning, population health and research. Now, Digital has already had a bit of a shout out, but I'm going to do it again because they've done fantastic work in the last year. And it's a lovely link, again, I think, between the work that HDR UK has funded into the work that the NHS has adopted into becoming business as usual. So I wanted to flag two core things here. One is the NHS Digital MVP of its trusted research environment, which has worked with DataCan, with the BHF data centre, and is expanding out and really trying to, again, leverage from expertise and insights across the ecosystem in terms of making the NHS digital data assets available through ATRE. Through Digitrials, and I'm not sure if the number's now gone up, and if Heather's still in the room, she can tell me if I'm wrong, recruited over 125,000 participants into the Grail Gallery study, which has had over 1 million invitees of the inclusion-exclusion criteria of those between 50 to 70 without cancer diagnosis in the last 3 to 5 years, and finding the right cohort both socioeconomically as well as ethnicity across the length and breadth of the country. That's something NHS Digital is well set to do. It has that global view across the system, and that's what we want to expand out and support more. So we go from one Grail and one early detection study for cancer into 5 to 10 of those per year. So that really, again, back to Mark's point, how do we shift to early diagnosis, detection, and prevention of disease? And finally, we're working with industry colleagues around how we begin to embed EHR systems into electronic data capture for clinical trials. How are we bridging the gap between care data that's been collected for care and data that's collected for clinical trials, and remove so much of the gap of there being duplication of the data across the system? So how can we shift and reuse data once rather than creating copies across it? And finally, just a couple of pieces around supporting that navigation work, as well as this research volunteer register, which is our work with the NHS app team about how we begin to offer more opportunities to people to put their hand up to say, I would like to be part of research. To focus on the trusted research environments for a moment, and again, I think this is picking up one of Mark's points, and I didn't ask him to talk about better collaboration, but learning lessons from the past has been how can we build a set of assets that are interoperable, linked, and collaborative from the outset. This is not a system that's intended to be 8 to 9 to 10 TREs that build from scratch separately. They are nodes in a network from the outset. They will be interoperable. They will have multimodal data availability. They will run at different speeds. We're not expecting everybody to come overnight, but that what we need to build is a business as usual approach to data availability within the NHS that covers the length and breadth of the country, and that considers primary, secondary, and tertiary care, as well as EHR, mental health, imaging, pathology, genomics. That takes time to shift, but is a core fundamental component of where we'll be focused in the next 3 years. That's complemented by our investments nationally, and what we want to see is a better linkage and flow of data both from regional to national, as well as national back into the regions. So SUS and HES data should stop being sat in NHS Digital, but not in the hands of the people in the ICSs. We need to support the better flow of data from the national level back into the regions. And we also need to better integrate the genomics data that is being more and more generated as part of NHS standard of care delivery. So we'll be working to invest individually in these components, as well as supporting linkage, interoperability, standards, and common best practice across these. And I would be really keen to hear from all of you what we should do, what we should learn, what we should definitely not do that you've had the pain and experience of going through, so we can deliver a set of infrastructure that really helps the NHS have a solid platform for research-enabled innovation. So the programme benefits, just to summarise a little bit of what we're aiming to deliver overall, is that these really do sit across those 4 use cases, so that we're supporting impact for patients and the public, that we're really tackling some of the issues around trustworthiness and transparency, and meeting needs of patients in terms of unmet needs, demand in the system, and the health inequalities that vary across the length and breadth of the country. That through these investments, we don't add to the workforce burden, that we can collect once for care and we can reuse it for planning, population and research, and how we build that in across a common set of infrastructure investments, so that whether you are accessing it through a secure data environment, directly in your EHR as part of care, that we're linking up that data much more effectively through ICSs, through GP practices, all the way up to the national level. And that for researchers and industry, that we are providing what we've heard you want and need through the pandemic, taking on board some of the speed, agility, simplicity of processes that appeared during the pandemic around contractuals, information governance, commercials, and then we make it more straightforward, efficient, and predictable how to engage with the system to undertake research and innovation using health data. So that's a little bit of where we're going. As I say, I'd hope it would be apparent throughout this that this leverages and tries to bed in a lot of the learnings that we've gained from the digital innovation hubs, from the centres of excellence, from a range of work underway across the Alliance and across the ecosystem as a whole. And we're really looking forward to going on this journey with you in the next 3 to 5 years. Thank you.
Have we got any roving mics available? I've got 2 here, if necessary. 3. We can share this one. Would anybody like to ask Claire a question? We've got a couple of minutes on the timetable. I just thought, given how important the integration of what we've been doing, making sure that it works effectively with the NHS. Obviously, the NHS in England, we need to look across the rest of the UK. But just wonder whether there are any particular sort of questions or comments people might have. Mark.
I've just got one comment, which is fantastic. We must stop talking about data owners. I think we are all data custodians. Basically, the ownership is actually the beneficial ownership for all of us as patients. And I think owners came up earlier, and I just sort of feel this is a difficult area. We don't even own our own data. You know, our date of birth is not something that we own, actually. There's lots of things we don't own. But I think this will only work if we recognise that we're custodians of all this information for the benefit of our health.
The easy one is just say, yes, Mark, I agree.
There's an interesting question about the language that we use, I think, not just on data controllership. I think we've now got the roving mics, and there's another question. We've got this one over there.
You're being much more tame than the Royal College of Pathologists were, I'm just going to say. So if you want to get competitive.
So, hi, Claire, Charlie Hooper. I'm pleased to hear what you say. It sounds very exciting. Could you say the link with other areas? I know you focus on research, but what about things like the Federated Data Platform, those kind of things? Are you working alongside them?
So yes, and I didn't bring it up, but I think it's one of the advantages. So I joined NHS X in June of last year, and although it's complex, the merger of NHS Digital, NHS X, HEE into NHS England actually helps to tackle some of this. The size and scale of the problem is huge. You have to break things down to constituent parts. But yes, there is, internally, we're working through a whole system architecture top to bottom, and what happens locally, regionally, and nationally across care, planning, pop health, and research. And that we synergize where we can, but we also recognize where there are divergences. So there are a number of things around research use cases that you do not need to worry about for planning and population health, but we cannot lose that quality, completeness, timeliness, and raw quality in terms of the research agenda. So I am lobbying hard internally for you all to make sure that stays flowing through the system for research.
Thank you for that, Claire. Next question.
Hi, yeah, very interesting, thank you. I noticed on one of your slides in talking about the TRE provision from the national TRE that the aim for October 23 was to enable open safely tools. Is that going to be the only game in town for accessing the national TRE data, or there will be other opportunities or capabilities?
So the open safely approach to access won't be the only one that the TRE offers. I don't know if that's the question, whether it will be the only TRE, which is a slightly different question. But the open safely model is not the only way we'll be making data available within the national TRE, no.
Sushil had his hand up very quickly there, so first.
I've goaded you all into asking questions, though.
Two-part question. One is on, if you had a magic wand, infinite money, infinite resources, and convinced everybody in the NHS, what would you do first? And the second part of the question is, same for HDI UK, if we could help support you, what would you ask us to do?
Okay, I was asking for questions, but we really went tough there. Magic wand. I think it's the really not exciting bits that we just need to put to bed. So can we fix some of the standards and interoperability pieces? Can we start to address quality of data at source? So if I had infinite money, infinite workforce, didn't need to worry about recovery and resilience and everything else, quality at source, enhancing the appreciation and value of the people that put the data into the system, which is not often the highest paid people in the biggest jobs. So valuing how data is created in the first place. And then a little bit of enforced, let's play slightly nicer around standards and interop, I think. And in terms of HDR UK's role, I think there's two strands for me. One is keep embedding your know-how and expertise into policy so that it gets docked in for the benefit of everybody, not just those who have been funded through HDR UK. And really that hopefully by the work I'm about to do, it means you can focus on the really exciting bits and less of the dull bits that I'm going to be focused on. So go do exciting stuff.
Thanks, Claire. I've got time for 2 more questions, and since my boss has got his hand up, Andrew, do you want to go next?
I'm nobody's boss, I tell you. Claire, this is absolutely fantastic, a great opportunity for joint strategy. And actually, this is about sustainability of healthcare in the future, so we need to get it right. Rory this morning gave a very eloquent talk about communication and how we weave that in from day one. So what are the plans to weave in the publics, but equally important, the professions into this program so that they own it?
Great question, and I nodded to it but didn't go into it. So I think there's 2 ways that we're approaching this. So one is through Data Saves Lives overall, and there is a commitment to a national conversation around data. So there is something that is independent of my program in terms of research or the Federated Data Platform or GPDPR or anything else that the NHS progresses around talking about data better with the public. There is also a strand to that, as you noted, around the professions. And I think that, again, that's partly about communication and comms. It's partly, I think, for me, around how we build out the conversations around information governance and better understanding about how we are the custodians of people's data and what is the balance of benefit versus risk and how we're thinking through that in a much more collegiate way. So those are 2 core strands that across the organisation we'll be engaging in. And then obviously within my work specifically, how do we approach commercial value of data? What do the public want to see? What do they care about in terms of the specifics of within research rather than data use across the system as a whole?
Thank you. Final question, we're going to go to one of our patient reps at the back. Tony.
Thank you. Anthony Tutor from Breathe and Alleviate. My question is more of a dream. I think patients really want connected data. And when will we see, and what are the blockages to stop my GP record being linked to the different hospitals I go to so I can log in and just have a different tab for each care setting? What if I had a tick box to include my data in research that gave consent? What if I could turn on and off things? This was the dream a few years ago, and I'm astounded that we don't have it. And I'm astounded that we don't have a shared record that goes across all the 4 countries. So if I go and visit Jill in Northern Ireland and I go into hospital, that doctors can't see everything about me if I want them to. And I think this would supercharge research in the UK if we had a record like that. So what's the barriers and how do we solve this problem?
So 2 observations. I think it's not a dream that anybody would disagree with. I think the pandemic has unfortunately got in the way of progressing some of those things that we'd like to do, that we were planning to do 2 years ago, that, hey, probably should tackle that nasty virus in the meantime. But it doesn't mean the dream's not still alive. I think both Data Saves Lives and Goldacre lay out a lot of the aspirations of how we approach that. There's a lot of pressure in the system, though, so just to kind of, not to put a grey cloud on the dream, but we have a very stretched workforce. We have people with fatigue from dealing with, can you just fix this, can you fix this, can you do the next thing? So there's a certain amount of doing this empathetically, incrementally but impatiently, but not losing sight of where we want to be and where that dream takes us. And I think we are headed there.
Okay, would love to continue, but I'm afraid we're well over time. But thank you very much indeed, Claire.
Thank you.